we'll do for the next sort of back-to-back sessions, we'll do thoracic trauma. The SAMS questions we'll do at the very end and encompass the material, and I'll try to highlight some of those things as we go through in preparation for that. So I have no disclosures. Now, the concept of the golden hour when we're dealing with trauma patients is that small window of time to identify and treat life-threatening injuries, and a lot of these are in the chest. You could make very easily this list into a dirty dozen, but of the first half dozen are the particularly lethal ones as well: the traumatic aortic injury, tension pneumothorax, pericardial tamponade, tracheobronchial rupture, cardiac rupture, esophageal rupture, and we could easily extend that to things like knives in the mediastinum. Those things look bad too. So we'll go through a little bit about imaging for thoracic injuries. We'll go through aorta, lung and pleural injury, airway injury, and then we'll sort of kick on part two and go through diaphragm, a little bit of chest wall, esophageal and cardiac, and then we'll review the SAMS at the end of all of that. All right, so imaging these patients in thoracic trauma, we begin with the chest x-ray. That's obviously our standard. And we give our patients the world's worst radiograph ever created, the portable supine crappy AP chest, which does a very nice job of making the mediastinum difficult to evaluate. In select cases, you can do an upright film in the trauma bay. It's more often that we would do that with someone that maybe has an isolated stab wound somewhere, looking for free air under the diaphragm or something, but it's another possibility. When it comes to doing a CT of the chest, obviously we do that with IV contrast, and we'll talk about technique and incorporating that into whole body CT. And then other tools that we have to evaluate these patients include angiography, and then more for select targeted diagnoses, the echocardiogram, the FAST, and water-soluble contrast swallow. Basically, what we're looking for is air and blood in the wrong places, and then broken bones, bad lines. So in terms of doing ABCs, I just stuck with A's and B's. So air in the wrong place is going to be a pneumothorax, and sometimes looking for subcutaneous emphysema is the first really nice clue on that trauma radiograph. Looking for pneumomediastinum, pneumopericardium as well. When we're looking for blood in the wrong place, we're going to be most sensitive about looking for mediastinal hematomas, blood in the pleural space, that's a hemothorax, other soft tissue hematomas that might suggest other injuries going on. We look for broken bones, particularly rib fractures, spine fractures, scapulothoracic injuries. And then bad lines. So tubes and lines obviously are things that as physicians can be done to make the patient get better or make the patient get worse. So let's begin with aortic injuries. And it's a pretty lethal injury, so left untreated, a lot of these patients are not going to survive, and most patients that get this injury actually do not come into hospital alive. The medical examiner, and we have one conveniently located between Bellevue Hospital and NYU Hospital. They're like 2 blocks apart, and right in the middle is the medical examiner. So they get a lot of these. The ones that survive and are brought in alive, again, there's still a high early mortality with these patients. It's a fairly rare injury, and it depends on your work environment. If you're near highways and things, you'll see these more often than I do in New York. It's hard to drive that fast in New York City. And there's not a lot of good clinical signs. So this winds up becoming a diagnostic imaging diagnosis. And so the pressure often falls on us. They're not evaluating someone in the trauma bay going, this person's going to have an aortic injury, and give you that information that they're clinically concerned about it. So on the left, we have our portable supine crappy AP chest. And our job is to look for normal mediastinal contours. Okay, I don't let the residents in the ER talk about mediastinal widening because it leads them into a very specific diagnosis, and that's aortic dissection, which is not the entity that we're dealing with. So what we see on the supine radiograph is poorly defined mediastinum, and we compare that with the upright image, and we can see the descending thoracic aorta to much better advantage. We can see the right paratracheal stripe, and so we're going to be much more confident to call that one on the right, the upright film, a clear mediastinum as opposed to the one on the left. The other problem with the supine radiograph when people talk about mediastinal widening is really it's a triangle. And so whatever number they say that they want, I can make it bigger, I can make it smaller perhaps, but it's not a reliable tool. So this mediastinal contour is abnormal. I think we're all happy to agree that that's abnormal. But here it is on the CT. We've got a lot of mediastinal lipomatosis in here, and there's a hiatal hernia in there too. But the vascular structures are fine, and there's no mediastinal hemorrhage. So we can be fooled. And again, all we're doing is using this tool as a somewhat sensitive marker to look at the mediastinum and then go on to do further imaging with something more definitive. So what we're looking for with our aortic injuries is loss of the aortic contour, which should be somewhere along that dotted line and is nowhere visible in this patient. Thickening in the right paratracheal space, presumably that's going to be hemorrhage tracking along there. Something denser than what the SVC needs. So anything that blurs that lateral wall of the trachea is going to be dense enough to become paratracheal thickening. Deviation of the trachea and NG tube, if there is one, moving over to the right, assuming your patient has a left-sided arch, and vice versa with a right-sided arch. And if the left paraspinal line ever extends up and over the aortic knob, that may be blood tracking in the posterior mediastinum. So this person has a traumatic aortic injury, and that's the language that we typically use when we're describing these. We will label them as a traumatic aortic injury. If you use the word traumatic dissection, we're going to run into a problem, and we'll talk about that in a little bit too. Another one, here's a patient on the backboard, although we're getting very few of these now. I think they're starting to remove the backboards. That EMS is not even using them anymore up in New York. But this one is abnormal. We've got too much thickening in the right paratracheal region, and the aortic knob is not well defined. And this person has a traumatic aortic injury.